Thank you very much again for the invitation and good morning. My name is Tabea Zhang and I'm a neurologist at the University Hospital in Tübingen in Germany. And today I would like to talk about how we can build a stronger evidence base for treatment in LCC with a particular focus on international collaboration, systematic data collection, and the evaluation of bevacizumab. This is a difficult topic because the needs are very concrete. Patients and families want to know what to expect and whether a treatment may help. Clinicians want to give reliable advice, but the available evidence is still extremely limited. So rather than presenting a definitive answer today, I would like to explain what prevents us from answering these questions at present and how our international multicenter study is intended to move the field forward. So let me begin with the central problem. Why is it so difficult to generate reliable evidence in LCC? A question we frequently hear from families is, should my child, my partner, or my parents start bevacizumab? As clinicians, we would like to answer this question with confidence, but at present, however, we cannot. LCC is an ultra-rare disease. Approximately 100 patients have been reported worldwide, although the true number is probably higher because some patients remain undiagnosed or unpublished. Most clinicians and even specialist centers will therefore only see 1 or 2 affected patients. As a result, almost everything we currently know comes from an individual case reports or very small case series. These publications have been extremely valuable. They help define the characteristic clinical and imaging phenotype, identify SNORD118 as the causative gene, and introduce possible treatments such as bevacizumab. But case reports were not designed to answer comparative treatment questions. Clinical assessments differ between centers. MRI findings may be described qualitatively rather than with a standardized score. Follow-up intervals vary considerably, and different studies use different definitions of improvement or progression. This makes it difficult to compare patients across publications. An apparent improvement in one report may not be directly comparable with stabilization in another one. And without understanding the untreated disease course, we cannot know whether a patient improved because of treatment, remained stable as part of the natural history, or would have changed in the same way without treatment. The central message of this slide is therefore simple. International collaboration and standardization are essential if we want to move from individual observations to more reliable evidence. This leads to an important distinction between what is already established in LCC and what remains uncertain. So, several important aspects of LCC are now well established. We know that genetically confirmed LCC is caused by B allelic variants in SNORD118. We recognize LCC as a progressive cerebral microangiopathy, and the combination of white matter disease, calcifications, and cysts forms a characteristic neuroradiological pattern. We also know that clinical and radiological improvements following bevacizumab have been reported in individual patients. These observations are important because they provide a biological and clinical signal that deserves further investigation. At the same time, the questions that matters most for our counseling and treatment remain unanswered. We cannot reliably predict how the disease will develop in an individual child or adult. We do not know the typical rate of progression, which features predict deterioration, or whether the clinical course differs between age groups or genetic variants. And regarding bevacizumab, we still do not know which patients are most likely to benefit, when treatment should be started, how long it should be continued, or which clinical and imaging outcomes should be used to measure a meaningful response. In short, we know what causes LCC and we recognize its imaging pattern, but we still cannot reliably predict the course of disease in an individual person. This uncertainty makes it also very difficult to determine whether a treatment is truly changing that course. This brings us to why bevacizumab was considered in the first place and what the current treatment evidence can actually tell us. Bevacizumab was considered because LCC is a cerebral small vessel disease, and increased VEGF expression has been reported in affected brain tissue. This raised the hypothesis that VEGF-mediated vascular dysfunction may contribute to the disease process. Bevacizumab targets VEGF signaling and was therefore considered a biologically plausible treatment approach. Encouraging clinical or radiological outcomes have indeed been described in a small number of treated patients. Reports include improvement or stabilization of neurological symptoms, and in some patients, reductions in cyst size or white matter abnormalities on MRI. However, we need to interpret these observations cautiously. Only a handful of treated patients have been reported worldwide. The published evidence consists of case reports and small case series, and there are no controlled prospective trials, and the patients differ substantially in age, disease severity, treatment regimens, and duration of follow-up. The assessments also differ. One report may focus on speech or movement, another on cyst size, and another on overall clinical stability. Short follow-up is particularly different in a disease that may progress slowly or fluctuate over time. This leaves several key questions unresolved. Which patients are most likely to benefit? Is there a stage at which treatment is more effective? How should treatment response be measured? And how long should treatment continue if a patient appears stable? We must also consider safety, especially when treatment may be forgiven over a longer period of time. So the conclusion is not that bevacizumab does not work. It is rather that the existing observations are promising but insufficient for treatment recommendations. We need a better framework in which these observations can be interpreted. To determine whether a treatment is changing the course of LCC, we need to bring together comparable clinical and imaging data from as many patients as possible. For this reason, we are establishing an international multicenter observational study. The current project is retrospective. We collect existing clinical information and available MRI scans rather than introducing a new treatment protocol. We include both children and adults with genetically conformed SNORD118 related LCC. Including the full age range is important because LCC can present from childhood to late adulthood. It allows us to capture the broad clinical spectrum and to study disease development across the lifespan. And in an ultra-rare disease, it also allows us to make the best possible use of the limited data that already exist. The study is coordinated in Tübingen with current partners in Belgium, Italy, and the United Kingdom. This is intended to be a growing network, and additional centers are very welcome. The key element is not simply pooling records. We want to evaluate them in a harmonized way with standardized clinical variables, a structured review of available MRI scans, and an LCC-specific imaging scoring system. The immediate goal is to create a robust natural history dataset, and in the longer term, this dataset should provide the foundation for prospective therapeutic studies with clearly defined and clinically meaningful outcomes. The next slide shows what information we plan to collect and how the clinical and imaging components complement each other. On the clinical side, we collect core demographic information, age and symptoms at disease onset, and the neurological phenotype. This includes seizures, movement disorders, spasticity, ataxia, and cognitive impairment, as well as measures of disability and functional status. We also document treatment history. This includes neurosurgical interventions and treatment with bevacizumab. with information on timing and duration whenever available. Genetic variants and longitudinal follow-up are recorded so that we can describe clinical trajectories rather than relying on a single snapshot. The imaging component is equally important, as we collect conventional MRI scans that were obtained during routine clinical care. These scans will be assessed in a standardized manner using an LCC-specific scoring system, which allows us to describe features such as white matter abnormalities, calcifications, and cysts more consistently across centers. Where serial MRI scans are available, we will compare them over time, and this longitudinal evaluation is essential if we want to determine which imaging changes reflect true progression and how they relate to changes in clinical function. We also collect exploratory information when it is already available, including MR spectroscopy, CSF data, and EEG findings. These tests are not required for every patient, and we are not expecting every center to have the same investigations. The retrospective design means that we use the clinical information that already exists while defining a common structure for its evaluation. Together, these clinical and neuroradiological data should capture the spectrum of LCC throughout the disease course and make patients from different centers more meaningfully comparable. Once these data are harmonized, we can address 3 questions that cannot be answered by isolated case reports. And the first question is, how does LCC develop across the lifespan? And by including children and adults and by reconstructing longitudinal courses where possible, we hope to describe both common patterns and the considerable variability between patients. The second question is, how are clinical and MRI changes related? An imaging change is most useful as an outcome measure when we understand whether it reflects a meaningful change in the patient's neurological function. We therefore want to identify imaging features that may track clinical progression. And the third question, it concerns treatment outcomes. We will explore disease trajectories in patients with and without bevacizumab. This comparison must be interpreted cautiously because the study is retrospective and non-randomized, and treated and untreated patients may differ in age, severity, or follow-up, and treatment selection itself may introduce bias. Therefore, the study will not provide definitive proof of treatment efficacy. Its role is rather to generate hypotheses, identify patterns, and determine which clinical and imaging outcomes can be measured reliably in future prospective studies. Ultimately, the goal is not only to describe LCC, it is to create the methodological foundation needed to evaluate progression and treatment response in a way that is consistent across patients and centers. I would therefore like to finish with a practical invitation to everyone in the room. If you are a patient or a family member, you can speak with your treating clinician or can contact our study team directly. And if SNORD 118 related LCC has been genetically confirmed, we can discuss whether existing clinical records and MRI scans may be eligible and connect with the treating center regarding the next steps. If you are a clinician or represent a center caring for a child or adult with genetically confirmed LCC, we would be very interested to hear from you. Collaboration may involve contributing available clinical information and MRI scans, including serial imaging when available. All data sharing takes place only after the appropriate consent and institutional approvals. In such an ultra-rare disease, every additional patient can make a meaningful contribution, and no single center can answer these questions alone. But together we can build a data set that's large enough and sufficiently standardized to move from promising observations towards more reliable evidence. My contact details are shown at the bottom of the slide, and I am very happy to discuss possible participation or collaboration. And I'm open for questions, and thank you very much for your attention.
Hi, Dr. Zhang, Ashley. I can't see whether or not you can, I don't know if you can hear or see me, but I do have a couple of questions if you can.
Yes?
Yes, Mandy, go ahead. We can hear you.
Thanks very much. Hello, Dr. Zhang. My name's Mandy Vine. I'm in the UK with my son Matthew, who has LCC. He's 21. We are delighted to hear about this study. I heard about the study through Yannick Crow about a year and a half ago, and also connected with Alex TLC in the UK. My son was diagnosed with LCC age 12, and after a very difficult patch with cysts through puberty. And basically, through our connection with Yannick Crow, who I keep up with fairly regularly over the last few years, we were advised about the Avastin Bevacizumab drug, and my son's actually been on the drug now for probably 6 years. I did try to connect with, is it Ludger Scholes, who I believe was leading the, and I sent an email, but it wasn't responded to. I don't know if it hit junk mail or whatever, but I don't believe currently my son's data is included within your study, and we are more than happy to share it because his experience has been extremely good and continues to be. He's, as I say, he's been on it about 6 years on and off. We had a couple of periods where he was on it for about a year. In the UK, there are funding issues with our National Health Service. So we had 9 months, then we had to reapply, and then we had some time off, and we had to reapply again. And so he did a couple of years on and off. And then most recently, he's been on it currently for the last 3 years, with a small break for other reasons. But essentially, he's not on any other medication. So his data is quite pure, if you like. And through that period, MRIs every 3 months.
Oh.
We are aware, when he started the trial, we weren't aware of anybody else. We were aware that a lad, I think in the States years ago, had tried the drug, and Yannick said to us, it's worth a go. We were in quite a serious situation, and it was worth a go, and it's kept him stable ever since. More than happy to. I'm looking at your map of the UK and looking like a centre in Liverpool, perhaps, or Liverpool, Manchester. We're down near London, but I would be very keen to connect with you separately, if I may, just for a conversation. But I personally, I know a lot of the people on this call and families, obviously, through our groups, and I would urge people that it's something worth considering if there isn't the complication of other medication. I don't know what your experience is of that, but certainly our experience and the radiology has pretty much shown cysts of, apart from one persistent big cyst that my son still has, which hasn't grown, it's stayed stable, slightly decreased. The other cysts have gone. He's had a very positive experience. Like you say, is it coincidence? We don't know, but he's been on it a long enough period now that we believe it's having positive effects.
The participating centre in the UK is the Ormond Hospital. I don't know.
Great Ormond Street.
Yeah.
Okay. Your map looked like it was up in Liverpool. So that's down near us, actually.
So we are in contact with the neuroradiologist in the Ormond Hospital near London, but Ludger Schulz is my boss, actually, and he gets a lot of mail, so maybe it got down in the spam. So you can just write me an email and tell me your hospital, and we get in contact with them and see if we can include the data of your son into our retrospective study.
Yep, fantastic. My son's based at St George's Hospital in Tooting in London. So Samantha Hettiger is his neurosurgeon.
Okay, that sounds good. We right now are preparing the ethic application for every center, and then we can start with with seeing the data and see how much patients we have. And just contact me and I will talk to your center if it's possible.
Thank you. Could I also just ask, what is, have you patients that have been on this drug longer term? What's the sort of longest term you have patients that you're studying currently? Can you say?
We have an adult patient. She's in her late 40s, and she was on bevacizumab for 2 years, I think. And we saw a clear radiological improvement by reducing the size of the cysts. But clinical, she was always the same. She never had any severe symptoms, although the cysts were huge. And if you just look at the images, you would think, oh my God, the patient must be very bad. But it was not the case. And she wanted to end the therapy by herself because she recognized some side effects we could not clearly connect to bevacizumab. So that's the reason why we don't know if it makes sense, because if the patient feels good and we don't want to treat an MRI image, we want to include the patient as well, of course. And that makes it so difficult. So it would be very valuable if you can include the data of your son.
Yeah, no problem. Thank you. Thank you very much.
You're welcome.
Hi, Tamaya. That was a great talk. This is Jamie Fraser. I am running a prospective and retrospective natural history and biorepository program for LCC, and we've been doing it since about 2017. We've already enrolled 28 families as of today, with about 40 people for whom we have data, potential outcome assessments, and we've built a biomarker that we're currently validating. We should email and get in touch and try to coordinate a little bit more, because we have that data for these people, including some of Mandy's son's data from about a couple years ago. So I would love to work with you a little bit closer on this, and I think we should chat.
Yeah, definitely. I'm happy to get an email from you.
And for our team here, because getting those records has been very onerous on both families and for our team, we will coordinate, and I will keep the folks who are enrolled on our study posted about that collaboration.
Okay.
Hi. Whoa. Thank you for this talk. My name is Boom. I'm a neurologist in St. Louis. I'm curious, and I don't know a lot about anti-VEGF inhibitors like Avastin, but my dad has wet macular degeneration and uses a lot of other vascular growth factor inhibitors that are newer and multimodal beyond Avastin, like Vabysmo, Eylea. And so I'm wondering if there's discussion, because other conditions have moved away from Avastin to dual agents that inhibit vascular growth in more robust ways with requirement for fewer injections. If there's a reason that Avastin is the initial go-to right now, or if there's opportunity to try other vascular growth inhibitors. I'm seeing a lot of reactions from Dr. Fraser, so but I'm wondering your thoughts as well. And I'm sure Dr. Fraser also has thoughts, so I'll just stop.
Tamaya, you go first.
Well, for us, the disease mechanisms are pretty unclear. And as I already mentioned, we first want to collect natural history data and see if there are phases of the disease where it may be more active, as you can compare to multiple sclerosis maybe. And then there are phases where the disease is absolutely stable. And if we want to include a second treatment, I think it's hard to distinguish which medication affects what in the neurological assessment, but also in the clinical presentation. So to my knowledge, there is no try to include another medication in the non-existing therapy plan of LCC, to be honest. It's just pretty much trial and error as far as we are in Europe. And no, maybe in the US you have further information, but we are just at the beginning to understand, and including a second medication would not lead to valuable data.
So with respect to the VEGF trials, I think they were initiated because VEGF was found in the lesions from the brain biopsy, and we saw that there were these vascular lesions. We have in our cohort several individuals who tried Avastin and biosimilars And several of them have had significant side effects or felt that the drug was intolerable, or that the side effect profile risk was not something they were willing to undertake given the risk for bleeding that individuals had already had in their cysts. And so there have been people tried off-label on other drugs more recently with some stabilizing effects. And as I mentioned yesterday, we have a plan to start rolling that out across our cohort and introducing that as an option for trial as an alternative to bevacizumab, since there have been a couple of significantly high profile issues with that with some patients. Well, I'm not
Okay,
dropping the
that's
name
interesting.
right this minute because I'm not ready to roll it out, but it is an immunomodulatory drug that is not actually directly VEGF related.
Okay, it sounds very interesting to me.
Okay, there's no more questions. So thank you so much, Dr. Zhang. That was a great presentation. Thank you so much.
Thank you.